Today's talk is going to be focused on the role of statins in liver disease. I have no financial relationships related to the subject matter of this program. We have 3 learning objectives. I'd like to discuss the various statins that are available, discuss recent safety changes in labeling, and discuss the effects of statin use in patients with chronic liver disease. There is a growing number of patients with chronic liver disease, especially patients with non-alcoholic fatty liver disease and chronic hepatitis C, who are prescribed inhibitors of HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis, known as the statins, to prevent cardiovascular disease. As a result, healthcare providers must weigh complex issues raised by the effect of statins on hepatic metabolism in patients with chronic liver disease. These issues have prompted studies that demonstrate underutilization of statins in patients with liver disease, as illustrated in this slide. In a survey of 937 primary care physicians from 138 academic centers in the United States that were provided 3 case scenarios conducted by investigators at the University of Washington, 71% of respondents would prescribe statins in a 45-year-old woman with an LDL of 240 milligrams per deciliter. But only 50% would prescribe statins if the baseline serum transaminase levels were elevated to 1.5 times the upper limit of normal, a significant decrease. And only 40% would prescribe statins in 55-year-old patient with known coronary artery disease, an LDL of 250 milligrams per deciliter, and chronic hepatitis C. The timeliness of this talk is also illustrated in this slide. February 28th of this year, the FDA released a bulletin based on the conclusion that serious liver injury with statins is rare and unpredictable in individual patients, and that routine periodic monitoring of liver enzymes does not appear to be effective in detecting or preventing this rare event. Statin drug labels were revised to remove the need for routine periodic monitoring of liver enzymes. Liver enzyme tests should be performed before starting statins and, quote, as clinically indicated thereafter. Also, in this news release and a subsequent news release in March 1st, lovastatin and simvastatin were contraindicated in patients on HIV and HCV protease inhibitors because of the increased risk of muscle injury. I'm sure you're all aware of the numerous statins that are available in the United States. 3 of these are on the formulary in the VA system: Lipitor, Lescol, Aldoprev, Livalo, Crestor, and the combination agents are non-formulary. Simvastatin or Zocor is the preferred agent within the VA national formulary. Pravachol or Pravastatin is second line, and Mevacor or Lovastatin is third line. Specific differences have been described among the statins. Simvastatin, lovastatin, fluvastatin, and atorvastatin are metabolized by cytochrome P450 systems in the liver, and pravastatin, rosuvastatin, and pitavastatin undergo minimal hepatic metabolism. The activity of statins is primarily dependent on their lipophilicity. It has been shown as late as 2007 that statins in larger doses and with lower degrees of lipophilicity, that includes pravastatin, rosuvastatin, atorvastatin, and fluvastatin, are associated with a higher incidence of elevated aminotransferases, with the relative risk listed here for highly lipophilic statins of 1.58 with 95% confidence intervals listed, and for mildly lipophilic statins, a relative risk of 3.54. Note that the relative risk for all statins is 3.1. Now, if we turn our attention to the use of statins in various clinical settings, this slide discusses this use of statins in patients with nonspecific elevated liver chemistries. As early as 2002, there was no increased risk of adverse events in one pooled safety analysis of 3 randomized controlled trials comparing pravastatin with placebo in 579 patients. Follow-up studies that were retrospective analyses also demonstrated no increased risk of adverse events. These retrospective analyses included over 2,500 patients. With respect to statins and metabolic syndrome-associated non-alcoholic fatty liver disease, trials supporting the use of statins are limited by the size and design, as well as by numerous confounding factors including concomitant drugs, diet, and exercise. But all trials demonstrate positive outcomes, including biochemical and histologic markers. This led the National Lipid Association expert panel in 2006 to consider statins safe and encourage the use in patients with non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. If we review the data in statins and chronic hepatitis C and the hepatitis C virus-associated dysmetabolic syndrome, statin therapy was not associated with a higher risk of significant hepatotoxicity in patients with chronic hepatitis C in a study run out of the Palo Alto VA. And statin use was associated with the improved spontaneous virologic response among both diabetic and non-diabetic patients receiving combination antiviral therapy in a study run out of the Kansas City VA. If we look at the data of statin use in patients with cirrhosis, the same National Lipid Association expert panel demonstrated no evidence that compensated cirrhosis is a contraindication for statin use. And interestingly enough, simvastatin has been shown to lower portal pressure and improve liver perfusion in patients with cirrhosis and portal hypertension. The use of statins has been specifically investigated in patients with primary biliary cirrhosis. As you know, primary biliary cirrhosis is associated with hypercholesterolemia in up to 95% of patients, although the relevance in cardiovascular risk remains controversial. Statins have been shown to be safe and effective in reducing serum cholesterol levels in patients with primary biliary cirrhosis. They modulate cholestasis, however, only in patients responsive to ursodeoxycholate administration. The role of statins in other cholestatic liver disorders, such as primary sclerosing cholangitis, is unclear. The role of statins has been investigated in post-liver transplant patients. There's limited evidence, but the data suggests that statins may be used safely in this group of patients. Finally, if we look at the role of statins and hepatocellular carcinoma, an increasing problem in our patients with chronic liver disease, experimental evidence demonstrates inhibition of vascular endothelial growth factor-related angiogenesis. In a large study run out of the Houston VA, statin use was associated with a reduction in the risk of hepatocellular carcinoma among patients with diabetes. Interestingly enough, statin use has also been shown to reduce hepatocellular carcinoma risk in hepatitis B virus-infected patients. And pravastatin specifically has been shown to prolong survival in patients with advanced hepatocellular carcinoma unresponsive to other therapeutic options. So in conclusion, cardiovascular disease is the leading cause of mortality in the United States. Statin therapy is the standard of care in patients with high cardiovascular risk, and the available evidence does not support withholding statins in patients with a broad range of liver disease. Thank you for your attention.